and that is collagen. We see an increase in the collagen that is laid down, and we also see a transfer of collagen subtype. We go from a more elastic form of collagen to a more non-elastic form. And essentially fibrosis occurs then, and this contributes to making the heart stiffer. So we have a problem with the muscle cells not relaxing like they should, and we also have an increased stiffness of the left ventricular cavity. Okay, the cavity size decreases along its short axis with aging, but essentially overall stays the same. There's somewhat of a shift in dilation of the aorta and also a dilation of the left atrium. As well, the senile septum, which is seen in elderly patients, which is a thickening of the interventricular septum at the base of the heart, occurs. This typically doesn't have any functional or pathologic problem, except in times when, suppose the patient is very sick and the heart rate is up, and sometimes this can actually act as an obstruction to blood flow coming out of the heart. The valves undergo changes as well. The valves become calcified, and there's a fatty degeneration of the annulus, or the tissue that surrounds the valve, and dilation of that annulus. It's very common to see large amounts of calcium laid down, particularly around the mitral valve, and this is referred to as mitral annular calcification. Women and hypertensive patients and diabetics tend to be more prone to this, and there is also a increase in embolic risk from this phenomenon. It's thought that strokes can occur with greater frequency in patients that have all this calcium laid down.
Does that have anything to do with the lack of estrogen?
That is unclear. The regulation of why valves become more calcified as we age is really unknown, but that is a possibility. It just, we don't have the data on that at this time.
Let me ask you, are we going to have a handout of your material?
You know, I have slides, I just didn't get a chance to bring it today, and I can get that to Lily at another time that you can pick up. Okay, can we go to the next slide? Having a little trouble since I can only see the slides here when you switch me. Okay, the coronary arteries become somewhat dilated and tortuous, and they also undergo calcification. And those are the normal processes that occur in those arteries with aging. A pathologic process is when we have, of course, a plaque and buildup of that plaque to form an obstruction of the coronary artery. The conduction system is also affected with the normal aging process. Again, fibrosis of those special tissues will result in loss of cells and specialized fibers. And in fact, if you look at the sinus node, up to 75% of the pacemaker cells within the sinus node are lost. And this is why so many of our elderly patients will have trouble with bradycardia and require pacemakers. There's also fibrosis of the atrioventricular node and the left anterior fascicle. And again, these can result in conduction blocks further down in the conduction system. The peripheral vasculature also changes with age. It's not up on the slide, but it tends to become, again, affected by the fibrosis process or the collagen laydown. So your big blood vessels, such as the aorta, become stiffer, less elastic. And the size and shape of the endothelial cells, which line the blood vessels, also change and produce possible deleterious effects. And all of those really have not been characterized. And there's also reduced synthesis of what we call good vasodilation substances, such as prostacyclin. And again, this can result in problems with perhaps elevated blood pressure. The response, we already mentioned that the response to calcium is maintained. However, there's a decreased response to a couple of things. Digoxin, which is a medication we used frequently in patients with heart failure, there's somewhat of a decreased response to that, and this has been seen really in elderly rats and dog models. There's also a decreased response to inotropic agents such as beta agonist. And it's unclear why this should be in the elderly, because the receptor number themselves are the same, the affinity seems to be the same, but it's something that happens after the receptor is filled with that beta agonist. Something is going on with the signal recognition and transduction. And then the heart, under a pathologic episode where it has to increase in contractility and heart rate in an elderly person, may not do the same thing from that stimulus. Okay, we mentioned the stiffening of the great arteries with age, and this will cause an impedance to ejection of blood from the left ventricle. It's harder to eject the blood when you're ejecting it into a very stiff vessel. And again, we mentioned this was due to alterations in collagen and elastin. This increased afterload then can translate to age-associated problems in systolic blood pressure, making the systolic blood pressure, isolated systolic blood pressure we see in the elderly, and also a widened pulse pressure. And both of those factors have been associated with increased cardiovascular disease mortality in the elderly patient. Let me just move on here. As well, this impedance to ejection causes signaling within the heart then to cause left ventricular hypertrophy. So the heart muscle itself increases in size and gets thicker. And in fact, this process starts really early on. Between the ages of 30 and 90 years of age, there is between a 1 and 1.5 gram increase in the left ventricular mass on a yearly basis. And this happens in people that are even free of disease. If you add somebody that's hypertensive, the hypertrophy or the increase in muscle mass will become much greater. We mentioned already the collagen deposition and the increase in the myocyte size, and also the stimulus of the increased afterload. All of these together will cause this increase in left ventricular hypertrophy.
So what does a normal heart say before the age of 30 weigh?
What does it weigh in grams? I don't really have those numbers. It depends whether you're looking at the left ventricle or you're looking at all the chambers. And I don't have the exact numbers with me today. But you know, we're increasing very small amounts, between 1 and 1.5 grams per year as we age.
Okay, thank you.
Okay. Okay, so all of these changes together, the stiffening of the arteries, which leads then to the elevation in the systolic blood pressure and a widening of the pulse pressure, the apoptosis of the programmed cell death, all lead to what we call left ventricular hypertrophy, or thickening of the heart muscle. This contributes then to the prolonged muscle relaxation, difficulty for the muscle to relax. And we also saw the stiffening of the left ventricle that can occur. Deconditioning of a person itself, a person that's not very physically active, can also translate to prolonged muscle relaxation. And then the final thing is to cause the E to A change that we see in echocardiography. And what does that mean? Mostly when the left ventricle fills, it's by passive filling. It occurs in the early stage. That's what the E stands for. And as we age and the pressures within that left ventricle get higher, there needs to be, there's less filling during that early phase. And we actually need the A phase, which is the atrial contraction, to push the blood in. And so the filling of the left ventricle in an elderly person becomes more dependent upon that atrial contraction. So if the atrium is not contracting, like in a patient with atrial fibrillation, that person is not going to be able to fill their left ventricle as well as someone that's in normal sinus rhythm. And this is why atrial fibrillation in an elderly person can lead to problems like congestive heart failure and cause a lot of symptomatic problems. Okay, and these symptoms or these findings together lead to what we call diastolic dysfunction. Okay, why can a patient present in congestive heart failure when they have absolutely normal contraction of the heart? Well, it's because of what's going on during diastole and the high pressures that the heart is seeing. And a patient may not be symptomatic during a normal resting state, but if you go to extreme exercise or if the patient is ischemic or very hypertensive or tachycardic, then symptoms such as congestive heart failure from an elevated pulmonary capillary wedge pressure can result. Okay, there are 4 things that affect the pharmacokinetics of drugs. And in the elderly patient, we always have to remember polypharmacy. Many of these patients are on many other medications aside from their cardiac medications. Antacids or anticholinergics can potentially decrease absorption of many drugs. And in addition, there have been some studies to suggest that the actual absorptive area within the GI tract in the elderly patient is somewhat decreased, and as well as motility. And there is a small reduction as well, blood flow to the small intestine. And I really will need my slide up, thank you. Distribution is different, and we're going to talk about that on the next slide, but there's a decrease in albumin in an elderly person, and so the protein binding of a drug binding to albumin will be altered, and this can affect what the free plasma concentration of that drug in the blood is. In a young person, it may not be very high, but in an elderly person, if they have decreased albumin, you may have a lot of this drug circulating free. And there's also a change in hepatic metabolism and renal function in the elderly patient, which may mean that those drugs that you're given to an elderly patient are cleared less efficiently, depending on whether they're metabolized in the liver or the kidney or both. Okay, and we mentioned the serum albumin. The particular drugs that this may affect are drugs such as lidocaine or Inderal. There's also a change. You decrease your body mass, your lean body mass or your muscle mass, and increase body fat. So those drugs that tend to be fat-soluble drugs will have an increased volume and distribution, while the water-soluble drugs will have a decrease. Okay, I'm afraid we're going to run into a time crunch here, so I want to just speed by. But the important thing to know is that renal blood flow does decrease as we age. And the GFR at age 70 is approximately 60% of what it is at age 20. So this leads to decreased clearance of many drugs. And I've listed some here: quinidine, procainamide, digoxin, atenolol. There's also a decrease, and that arrow here is misplaced next to decreased sensitivity to loop diuretics. That sort of floated up, and it's supposed to be on the bottom. There's also decreased hepatic metabolism, so this may prolong the half-life of many drugs, such as lidocaine or the lipid-soluble beta blockers. Okay, I want to switch to speaking, we're sort of switching gears now. Those are sort of the normal aging changes that we can see within the heart. And now go to talk about risk factors, presentation of angina and acute myocardial infarction in the elderly patient. Now, it's been said that the importance of some risk factors decrease with age, and we'll talk about this with regard to the relative risk versus absolute risk. There may be not so great a reduction in the overall relative risk. So in other words, if in a younger person, somebody says that there's a 3-fold reduction in the relative risk if you do behavior X, and in the elderly person, well, maybe there's only a 1.5-fold decrease. Well, if there are greater numbers of elderly patients with that disease overall, the total number of people that are seeing a resultant decrease in risk is going to be greater. So that's what we call the absolute risk. If we have more patients that are potentially have that disease, there'll be a greater reduction in absolute risk, while maybe the relative risk is not as great. We've already mentioned that there's a lack of trial data, and the randomized clinical trials did not include, especially those patients over the age of 80 years old. So we are handicapped when we look at risk factors and try to assess how they affect the heart. Okay. I want to start out with just saying that coronary disease is not an inevitable result of aging. And I think that's important because it will affect how we look at risk factor reduction in the elderly patient. If you think that everybody is going to get coronary disease and die of coronary disease, you have less of an impetus to then reduce risk factors in those patients. Okay. If we look at hypertension in aging, diastolic blood pressure will plateau at the age of 55. However, systolic blood pressure and isolated systolic hypertension both continue to increase with age, and that's why we tend to see many more elderly patients that have just an isolated elevation in their systolic blood pressure. And the first trial to really show that treating isolated systolic blood pressure was the SHEP, the Systolic Hypertension in the Elderly program, which showed that a reduction of blood pressures that were greater than 160 showed that there was a decrease in non-fatal MI and stroke and an improvement in left ventricular ejection fraction. So it is very important to treat these patients regardless of what their diastolic blood pressure may be. And if you look at the elderly population, depending on which age you consider elderly, at least 30% to 50% of patients overall will have isolated systolic hypertension. We can go back to the slide, please. If we look at the one question, and I'm going to just skip over pseudo-hypertension and hypotension for now just because of time constraints. A lot of people will ask, how low can the diastolic blood pressure go? And that's always been a concern, that if we're lowering the systolic blood pressure with medication, we're also lowering the diastolic blood pressure. And we know that the coronary arteries depend on some diastolic blood pressure to fill those arteries. And the answer to this, unfortunately, is pretty much unknown. But there is concern that if you're lowering, if you have a wide pulse pressure to begin with, and you're lowering the systolic blood pressure, that you're also going to run into a problem with filling the coronary arteries. And again, I think this has to be evaluated on a case-to-case basis. And I would honestly say I would wait until a patient is complaining of angina, and maybe if you correlate that with a significant reduction in the diastolic blood pressure, then maybe you do have to back off a little bit about how aggressive you're being with reducing their systolic blood pressure. And we just don't have a good answer for that right now. I think in older hypertensive patients, it's important to customize the agent that you're using. Some patients will have great difficulty tolerating one particular antihypertensive but not another. Elderly patients with respect to blood pressure reduction don't tend to do as well with beta blockers as do the younger population, and they seem to respond better to vasodilators like ACE inhibitors or calcium channel blockers or hydralazine. And my one advice is to really start low in blood pressure lowering, meaning that we don't start at the higher dose, we start at the lower dose, and we advance very slowly in the elderly patients because they are more prone to have episodes of hypotension. And this is a busy slide, but if you'll focus on the graph, this was to show, and this is treatment of isolated systolic hypertension in men. And if we look at what happens to events, which are the dark red bars, and mortality, which are the light pink bars, we can see that those patients with isolated systolic hypertension have much greater cardiovascular events as well as mortality compared to their normotensive counterparts. And so it's really well established now that patients with systolic blood pressures, particularly greater than 160, but even greater than 140, we should be considering for treatment. Okay, we're going to shift gears from hypertension and discuss cholesterol reduction. And again, I have to emphasize here that the studies in the very elderly population are not there, and the benefits of reducing cholesterol in the elderly are not as well established as in the younger population. But if we look at this trial, this was a very large trial, the 4S trial, which had all age groups of patients, more younger patients than older patients, but it did include some patients over the age of 60 years of age. And those are the patients that we see depicted here in the light pink bars. The study was not powered enough to look at a reduction in mortality, and so the graphs you see here under death, although there's been a reduction in both groups, it wasn't a significant reduction. But what it was powered for was to look at major coronary or cardiovascular events, such as a non-fatal myocardial infarction, or the need to go to bypass surgery. So these were all considered coronary heart disease events. And for both age groups, the less than 60 and the over 60, we can see a significant reduction in events, but that reduction is somewhat more pronounced in the less than 60 age group. And this is secondary prevention. These patients all had known coronary disease. So their reduction in cholesterol was considered secondary prevention. And the next slide, I'm going to show you a primary prevention trial. And this was the Air Force study, the AFCAPS trial. And this was done in elderly patients as well. 21% of their subjects were greater than the age of 65 years of age. And it was a very large population. Again, even though we had greater than 65 years of age, the patients that were, say, above 80 were relatively small in this study. These patients did not have coronary disease. These were otherwise healthy patients, although, you know, in this population, especially in the elderly, it's hard to know whether you're looking at a primary prevention or a secondary prevention, because a lot of these patients may have had what we call silent coronary disease and just not had known about it. But we're suspecting that most of the patients here were primary prevention, and if we look at the risk reduction received for the less than 65, or the dark red bar, we can see that was a significant reduction. Events were reduced by about 40%. If we look at the reduction in the over 65, our p-value is 0.08, so it doesn't quite meet significance, 0.05, but definitely a trend, I mean almost a 30% reduction. So it's felt that if these studies were extended, they had more patients of a greater age, that we may indeed see a significant benefit. So right now, if you look at the Society for Geriatrics, the ACC, the American College of Cardiology, the feeling is that the recommendation between the ages of 65 to say 80 years old, if you have known coronary disease, okay, you've had an event or you've had a catheterization shown coronary disease, that you should have, if your cholesterol is elevated above the NCEP levels, then you should have reduction of that cholesterol, first by diet, and then if that fails, to go to a drug. What about the over 80 age group? Well, I think if you have a healthy patient and you know they have a projected 10-year or greater lifespan, that there's probably some good evidence to suggest if their cholesterol is significantly elevated and if they have other risk factors for coronary disease, we should be treating those cholesterols as well. And again, on a case-to-case basis, if you had somebody with a malignancy or cancer, I don't think that patient is going to see the benefit from reducing their cholesterol. For primary prevention, what about those patients that have no known coronary disease? Should we be treating them? And again, I think if there's elevated, if they have other risk factors other than the elevated cholesterol and they're otherwise healthy, I think that there is evidence that perhaps they may benefit too. But I can't say that this evidence is quite as good as the younger population. Okay, smoking cessation, just really quickly, it's bad, your elderly patients should stop. There is benefits, and you can tell them, because people will say, well, I've smoked for 20, 30 years, or 40, 50 years, and well, why should I stop now? Well, because even in the patients, say, greater than 70 years of age, and the CAST study was a very large study that had a lot of patients, and even patients over the age of 70 years of age, and those that continued to smoke continued to have an increase in the risk of death and the risk of myocardial infarction. And so I think it's important to let your patients, especially your elderly patients, know that there is a benefit if they do stop smoking. And that benefit, as you can see, I've listed what the physiologic changes that the body goes through when you stop smoking. I mean, within 20 minutes of smoking cessation, you have a reduction in your heart rate, your blood pressure, and your body temperature normalizes. Within 3 days, you can see a significant improvement in your respiratory function. Your 3 months, your circulatory function improves, and there's said to be at least a 30% increase in your lung capacity. And within 1 to 2 years, you've decreased your cardiovascular risk by 50%. And within 3 to 4 years, that risk is essentially that of a non-smoker. So I think it's important to let your elderly patients know that, yes, there's a benefit even if you are elderly and you stop smoking. And the same goes for obesity and physical inactivity. We have a problem assessing this in the elderly because, again, we don't have the studies. The studies we do have with physical inactivity, particularly in men, we have seen that moderate exercise does protect against coronary disease. Benefits in the very old, of course, are unknown, and I think it's important to take into consideration the impact of orthopedic and also peripheral vascular problems that our elderly patients encounter. And, you know, I don't expect that anybody is going to be going out and running marathons, but there are some very well-structured classes now, whether it's water aerobics or low-impact type of exercises, and just even sitting in a chair and exercising for an elderly patient, I think, is better than being physically inactive. And this is also going to help build up and prevent osteoporosis. So I think there are a lot of benefits for getting your patients physically active. And in women, there is a strong relationship, and this extends to the elderly population, between an increased waist to hip ratio. And this is, you may have heard about the apple versus the pear body habitus. And this increase in this waist to hip ratio is a risk factor and a marker for cardiovascular disease. So it's something to look at, and it's said that basically only exercise and estrogen can reverse this type of a ratio. It's due to probably an imbalance between the estrogen and the testosterone. Some women are apples, some are pears. It's better to be a pear than an apple. But in general, you know, advocating weight reduction in very obese patients in the elderly, I think, may possibly have benefit in reducing risk. Okay, so just in summary, smoking cessation, I think, hands down, there were no ifs, ands, or buts there. The treatment of both systolic and diastolic blood pressure is important. I think cholesterol lowering for the secondary prevention in the elderly I think we have enough evidence to say that we'll see a benefit here, and possibly for the high-risk patient for primary prevention in the elderly. I didn't have time to really speak about aspirin, but there is no evidence to suggest that aspirin is going to be any less effective in the elderly patient. Of course, you'll have to balance this with the risk benefits of giving aspirin in patients that may also have contraindications to aspirin, such as GI problems, and then exercise as well, as much as the patient would allow. There are diagnostic challenges in diagnosing coronary disease in the elderly patient. Since the majority of elderly patients lead a relatively sedentary lifestyle, they may not have symptoms until they have their acute myocardial infarction. Cognitive disturbances, dementia particularly, may make it difficult for the patient to describe their symptoms as to what's going on. They just may be able to tell you, I don't feel well. Atypical symptoms, dyspnea or shortness of breath may be more common than actually having chest pain. And this will go back to the fact that remember, those elderly patients have very stiff ventricles, and so they may actually be perceiving their coronary ischemia as shortness of breath rather than chest pain. And there also may be a reduction or as far as the pain receptors and how, as we age, how we perceive pain. And also many of these patients will also be diabetics who have a decreased pain sensation. And of course, we already mentioned the inadequate representation of elderly in clinical trials, which makes management decisions somewhat difficult. The physical exam in somebody presenting, say, with an acute myocardial infarction or unstable angina is unfortunately not very helpful because many of the patients elderly patients may already have the findings that we would particularly associate with ischemia, such as an S4 Gallop-on exam, paradoxical splitting of the second heart zone, or a systolic murmur of mitral regurgitation. Those findings may all be present in many elderly patients that do not have ischemia. As far as stress testing, there's a lot of challenges in the elderly population. The first and foremost being that many can't do an adequate exercise test, and certainly not to the same type of protocol that a healthy younger person can do. So for those patients, we need to really look at pharmacologic protocols such as persantine or adenosine, combine then with a nuclear image such as thallium or echocardiography. Less intense protocols, if you really do want to get an estimation of how well an elderly person can exercise and how that impacts for ischemia, there are less intense protocols. Not everybody has to exercise on a Bruce protocol. And it's important to check with your stress lab to see what other protocols that they have, and sometimes it's just getting them on a not increasing the treadmill elevation as quickly and a slower speed, and you'll see those patients be able to exercise for longer periods of time. As well, many of elderly patients will have a baseline abnormality on their EKG. And because of the baseline abnormality, they may not have an interpretable EKG with exercise. And again, we would recommend at this point going towards a nuclear study or an echocardiography study. And this is particularly seen in patients on digoxin. The EKGs are essentially uninterpretable with exercise. There's many, besides coronary disease, we've spoken about conduction system disease that occurs frequently in the elderly, and all these concomitant diseases combined will make management of coronary disease more difficult. Because of conduction system disease, you may be limited in what medications you can give your elderly patients, such as calcium channel blockers or beta blockers. And sometimes we even need to put a pacemaker in just to treat symptoms of angina in a patient. Very important is that there is a higher incidence of calcific aortic stenosis in the elderly population. And this is characterized by a very typical murmur, systolic ejection murmur that is late peaking that radiates up into the neck. A careful physical exam in someone presenting with angina, especially an elderly person, is extremely important. And if you are suspicious, an echocardiogram can identify this problem. And this will greatly have impact on the way you manage a patient. Atrial fibrillation as well is a very common entity in the elderly. The incidence of atrial fibrillation increases with age and can make management quite difficult. And sometimes your patients may be having episodes that they're unaware of and have an ischemia at that time. And so if that is suspected, sometimes a Holter monitor can pick up these episodes. And sometimes if you just control the atrial fibrillation, this very fast ventricular response, the patient's angina may be treated adequately enough. Congestive heart failure as well is very common, and also atherosclerotic plaque of the aorta we'll speak about when we talk about bypass surgery. Okay, it's also important to remember that there are many reversible factors to remember to look for when you have a patient with angina. Severe anemia will greatly impact on angina, and so a hematocrit should definitely be checked in all of your elderly patients. Hypothyroidism, hypertension, congestive heart failure, and also non-compliance, which is a big problem in the elderly population, maybe for reasons of cognition, but also because elderly tend to have more side effects with medications, and if it doesn't make them feel well and makes them feel worse, they're certainly not going to take it. So those factors are all important to look for. As far as medical therapy, it's very similar to the younger patient. The anti-anginals we use are the same. We want to control the double product, which is a combination of the heart rate and the blood pressure in a patient with angina. We like beta blockers, especially in patients that are post-MI, because not only do they control symptoms, but they're associated with decrease in mortality overall. And aspirin also is very important in your patients that can tolerate it. And just remember, we spoke about before when initiating these agents to do it slowly, because the elderly will run into more problems with hypotensive effects. Now, if we look at presentation of acute myocardial infarction in the elderly patient, I hope you can all see the diagram well enough, but I'll point out by colors. The most common presentation in the elderly, and I've broken this down into quite several different areas, but is of neurologic symptoms when they present with an acute myocardial infarction, including confusion in 17% of the patients, where a stroke can present in 7%, and syncope in another 7%. So already we're looking at 31%, or a third of your elderly patients presenting with a heart attack may present with neurologic type symptoms and not have any chest pain or shortness of breath that they can relate to you. Now, another 20% of your patients will present with congestive heart failure or shortness of breath. The percent of patients presenting with typical chest pain that we would associate with an acute heart attack are only 19%. So less than a fifth of the patients, elderly patients, will actually have classic signs that we associate with a heart attack. Palpitations, and then a big category called other, and this would be very atypical. I don't feel well, I feel weak, just a whole handbag. So you really have to be a good detective in the emergency room when you have an elderly patient that presents. And I don't think any elderly patient that comes into the emergency room, with vague symptoms should leave without having an EKG, because you'll be surprised often. Okay, the characteristics of a myocardial infarction in the elderly are also different than in a younger person. There are more non-Q-wave MIs or less transmural MIs. And why this is so, we really don't know, but it suggests that an elderly patient has less of a chance of completely blocking the coronary artery. So they don't have a transmural or a heart attack that goes from one side of the heart to the other side of the heart. Okay, and this means that their EKGs will be different. They won't have as much ST elevation as a younger person will have, and more ST depression will be seen. Also, there's no difference in the size of myocardial infarction between the young and the old, yet we see more dysfunction within the left ventricle, more congestive heart failure, and perhaps this is due again to the diastolic properties we discussed rather than systolic properties. Electrical mechanical dissociation tends to be a more common cause of death, and there's also a marked increase in cardiac rupture in the elderly population. And so this may be a patient that's looking otherwise stable at the time of the myocardial infarction, and within a day or two they all of a sudden spiral down, and oftentimes we'll find out because it's rupture of the wall. And there's a question of whether in the elderly there's more acceleration of the remodeling process that occurs after a heart attack, which remodeling is a dilation of the left ventricle, less effective functioning. And so there's a question of whether that process may be accelerated. Mortality in the elderly patient with a myocardial infarction is very high. I mean, this exceeds, if you look at this trial, which included patients over the age of 75 years of age, if you were greater than or older than 75 years of age, your mortality in hospital was almost 18% versus 2% for a younger patient. And if you look at this registry, and this was a registry of patients that they looked at, if you looked at the treatment then received, notice that the patients that were less than 75 years of age were much more frequently treated with thrombolytic therapy, with angioplasty, with CABG. So we wonder if some of this increased mortality is due to the reluctance on the part of physicians to then go ahead and treat the elderly, who in essence would benefit probably the greatest from the treatment. But there's always and you do have to be cautious, but there's always, I think, sometimes too much caution, and the thought that if we don't do anything and if we take things very slowly, then that's better for the elderly population. And sometimes that's true, but in the case of acute myocardial infarction, we know that the treatment we institute within the first 24 hours is the most crucial and the most likely to impact on mortality. Even aspirin use, you can see, is much less in the elderly population, and this has been a long-standing problem. And again, physicians are even a benefit such as aspirin that's been proven to be quite beneficial in an acute heart attack, physicians are less likely to institute that therapy in an elderly person. Okay, that's a cue that we need to go to the transparencies. I want to talk a little bit about what therapy we should be looking at in our elderly patients. And if, I think it's important to realize that there are, it's fine if you're at a tertiary care hospital that has a cath lab that can take people right in if they come in with an acute heart attack to open up the blood vessel and do a percutaneous intervention. But that's not available in a lot of community hospitals, and thrombolytic therapy is still sort of the mainstay. So how safe can we feel giving our patients thrombolytic therapy? Well, I think it's important to look at ISIS-2, which was a trial that did actually include a lot of elderly patients in that trial. That was one of the few trials. And compared with conventional therapy, there's a 46% reduction with thrombolytic therapy. And this is almost twice that even seen in the younger population. And so in these patients, I mean, you can really have an impact by getting that artery open. But there are eligibility requirements for thrombolysis. And if a patient's had a recent stroke, if they're very hypertensive, they may not be eligible. And we see that not only are elderly patients less eligible, but then again, that whole thing, the physicians tend to even underuse it in those patients eligible for thrombolytic therapy. I don't have on here, but as far as the choice of thrombolytic therapy, we have the agents, older agents such as streptokinase and those such as TPA. And TPA in the elderly actually has been associated with more hemorrhagic cerebral events than has streptokinase. If we look at the incidence of stroke and intracranial hemorrhage, it's increased, and I'm going to show you another slide of a trial that included significant numbers of the elderly, but it is increased. And if you're over the age of 80, an intracranial hemorrhage, up to 80% of those are fatal. So it's definitely something to consider. And we'll look at a study that looked directly between angioplasty versus thrombolytic therapy. So again, PCI or percutaneous coronary intervention is a good option if it's available. But also in the elderly, there can be technical challenges. Just getting access to an artery can be difficult in the cath lab because of peripheral vascular disease. But if all goes well, the procedural success rate can be good. And the next trial I'm going to show you is the PAMI trial. And this looked at patients of all ages, but included a significant number of patients greater than the age of 65 years of age. And essentially, they asked the question, what was better in this group of patients? Was it better for them to go directly to the cath lab and get their artery open, or is it better to have TPA or thrombolysis? And if you looked at the rate of mortality, you can see that those patients go into the cath lab over the age of 65 years of age really fared better, a 5.7% mortality versus almost a 15% mortality. And if you look at hemorrhagic events or hemorrhagic strokes, they were almost exclusively seen in the angioplasty group, 6% incidence versus, in the thrombolytic group treated with TPA versus essentially 0% in the angioplastic group. And also in those that went for angioplasty, if you look long term, there was a marked decrease in recurrent ischemia, and this was not seen in the group getting angioplasty. So I think the benefit of angioplasty, if you have it, is a real one. I think there are less complications as far as stroke, and it's a very good option in the elderly patient. I'm going to go back to slides now. Okay. If we look at adjunctive medical therapy, we mentioned beta blockers and aspirin. Both have been shown to reduce mortality after a heart attack, but in actuality, both are underused in the elderly population. And in fact, beta blockers have been said to have at least the same, if not more, effect for prevention of a second heart attack in the elderly population than as in the young. Aspirin, studies have shown that up to a third of patients, elderly patients with an acute heart attack, are not treated with aspirin in the first 2 days, and that we know that's a life-saving medication. Angiotensin converting enzyme inhibitors such as captopril, fascinepril, in those patients, particularly with an ejection fraction less than 40%, they're equally effective independent of age, and they should be used routinely. Okay, a little bit about angioplasty, whether it's for acute myocardial infarction or just for control of angina. And I wanted to particularly separate patients between the 65 to 80-year-old group, and then those over 80, or the very old, or the octogenarians. And there seems to be a breakdown as far as the success rate and the complication rate for these patients. Those over 80 years of age are the ones that have more complications, and their outcomes are not as good as far as getting that artery open and improvement. We've also already spoke about just the problems getting access. So if there's difficulty getting access into the femoral artery during a case, that patient is more at risk for a complication, developing an aneurysm or dissecting the artery. Oftentimes, the coronary arteries are so calcified that even trying to deploy a stent or balloon a lesion is impossible in the very elderly. Multi-vessel disease or diffuse disease in the coronaries is a more common entity in the elderly. And so when you have this, that may limit the effectiveness of angioplasty. If you want to dilate a lesion that's very proximal in the coronary artery, well, you may be able to do it, but if there are several lesions after that, it may not be of any help to the patient. Chronic renal insufficiency in the elderly is more common, and therefore a dye load that you get in the cath lab may harm their kidneys, and so that's always something to be aware of. Cerebrovascular complications or stroke is a risk that we will describe to anyone undergoing a cardiac catheterization, but because of plaquing within the aorta being more common in an elderly person, that risk of stroke is going to be somewhat greater. So let me go on. I think, Lily, are we at time almost? We're fine. Okay. If we look at survival after percutaneous coronary intervention in patients over the age of 80, and we look out 5 years, I hope this graph projects, but the top line looks at overall survival. And you can see that after about a 5 to 6 year follow-up, we're looking at maybe a 60-70% survival. Not bad, but how much of that survival is actually event-free after meaning no more myocardial infarction, CABG, et cetera. And you can see that the next line depicts that, or the line with the squares. So we're already getting a decrease, that less patients, and I think our event-free curve goes down to 50%. So meaning that 50% of your patients then by year 5 or 6 have either died, had a heart attack, another heart attack, or they've needed bypass surgery. And if you go down to the last line, that's the line with how many patients are free of needing another angioplasty. And again, your success by the time you're at 5 to 6 years has fallen now to 20%. So the majority of your patients, by the time 5 to 6 years rolls around, will have needed another procedure, or they have died from their coronary disease. So while it may be a good fix in the immediate time post-angioplasty, sometimes it's not the complete fix that we want, even for our elderly patients. And that's why we have to consider CABG, or coronary bypass surgery, because we're able to obtain more complete revascularization by CABG in many of our patients. But it's a very tricky process, because not every elderly patient we see will be able to tolerate the surgery or have a good outcome. So I think it's important to know that we're not necessarily, we don't think that CABG in the very elderly is going to give us a goal of improving survival. But that's not our main goal. Our main goal is to return them to a quality of life that they're happy with, and have them relieved of their symptoms for the time that they do have left, and to return to independent living. And if we look at just a small study that compared 3-year survival of patients 80 years and older that had coronary disease, that underwent CABG versus that were treated with medical therapy. And this wasn't a randomized trial, so we have to remember that. These were doctor decisions. But that a higher percentage of those that went on to CABG than were treated with medical therapy had a better survival. There were more patients at the end of 3 years that had gone on to bypass surgery. Okay, wanted to go through a case presentation. This is a patient that came to our service last year. She was an 85-year-old woman that had a history of high blood pressure and elevated cholesterol and some osteoarthritis, and was relatively healthy. Presented to her primary care physician with a history of increase in dyspnea on exertion, but no history of chest pain. She was a non-smoker, no prior history of coronary disease. She lives independently, was able to fully care for herself prior to these symptoms, and had some minor problems in her past medical history, was on aspirin and some antihypertensive agent, Norvasc, and was also on a nitroglycerin patch that was prescribed by her physician after these symptoms. Her physical exam, she had some mild systolic hypertension, S4 gallop, really pretty much unremarkable, no signs of congestive heart failure. Her EKG was normal sinus rhythm with the right bundle, and the thallium, the prosantine thallium that her primary care physician got, was positive for ischemia in 2 areas, the anterior wall and the lateral wall. And so at that point, she was referred for a cardiac cath, which was done in an outside hospital. And at that, their conclusions were that she had moderate disease in the left anterior descending artery, both proximal and mid, and moderate disease of the mid-circ. And she was referred then to our hospital for a 2-vessel percutaneous intervention. Well, prior to the intervention, we repeated the diagnostic cardiac catheterization, and this is the first shot that was obtained. And that little L-shaped at the upper left-hand corner is the catheter injecting the dye. Next to that is the left main coronary artery, which we're injecting. Now, most of the body looks okay. If you look at the very beginning of that left main, you can see this very, very tiny opening, and that is a very severe stenosis of the proximal portion of the left main. So she quickly became not a angioplasty consideration, but we had to consider her for bypass surgery because of this very severe left main stenosis. So the surgeons were called immediately, and she went to bypass. She had a pump time of approximately 80 minutes, and they did 2 grafts, one to the left anterior descending artery and one to the OM artery, which is a branch off the left circumflex. By post-op day number 2, she was extubated. She did need some blood. She was out of bed to a chair by post-op day number 3, was somewhat confused, but by post-op day number 4, she was walking with assistance. She did run into some problems with post-operative atrial fibrillation. She was short of breath with ambulation, had a little bit of atelectasis in her lungs, but overall was doing well. She was discharged approximately within a 2-week period from the time she was initially admitted. So a little bit of a longer course than a younger person would have had, but she was discharged initially to a rehab facility and then quickly was home. And somehow my slides got somewhat out of order, and I apologize for that. She, I can tell you now, is doing very well. She is over a year post-bypass. She's living totally independently, and she is free of all symptoms. So I think it's important to realize that there are some patients, and we have to be careful how we select the elderly patients, that will do well with bypass, and bypass may be the best option for them. And it may not only improve quality of life, but it may ultimately improve survival, although that's not our ultimate goal in the elderly population. If we go on to look at what types of elderly patients do we end up looking at for CABG, well, women tend to live longer. And so more of our elderly patients we're looking at for CABG are women. More of them, they're sicker patients because they've had more years to have other things go wrong. Have more blood pressure, more congestive heart failure, concomitant cerebral vascular or carotid disease is a problem, lung disease, and impairment of their renal function. So overall, a sicker population going to bypass than, of course, our younger. And what are different about the vessels of an elderly person versus a younger person? Well, we mentioned there's a higher incidence of more diffuse disease, so it's more likely that you're going to have multiple lesions in more arteries. And there's a higher incidence of the left main stenosis, which we had just seen. So more diffuse and more distal disease. And this, the fact that the disease can be diffuse and more distal, it may make it difficult for the surgeons to even be able to tie a graft in after the blockages. And if I can have my slide back. Okay, thanks. So this greater number of complicated stenoses, the coronary calcification can also make it a real bear to be able to just tie in and sew that graft down. And also the tissues tend to be more fragile in the elderly person. There's a higher bleeding rate. And so technically, CABG in an elderly person for the surgeon can be much more difficult, leading to longer time on pump, more cerebral vascular, and there was an article recently in the New England Journal about an increase in confusion and neurologic symptoms after bypass surgery. So there is a lot to consider before you do send a patient. So what patients should we select? Well, a patient like I presented, somebody that's in very good physical health. If you have someone that goes into bypass and their health overall is not good and they have a lot of problems, well, they're usually not going to be much better after bypass, and it's going to be harder to rehabilitate them. Somebody with a good cognitive status. I think, you don't want to send somebody that's very demented. It's just not doing them any good, and they generally will come out being more confused after bypass surgery. You have to consider comorbid conditions, the lungs and the kidney, and also the perceptions of the patient and their family. Do they really think that surgery is going to help them? Are they positive about going into surgery? Because we've known that how a patient feels about a particular experience will have a great impact on how they recover. And also, of course, we need to consider how serious the disease is. Okay, there are a lot of technical considerations. I won't spend a lot of time on this, but I'm going to show you a picture of an aorta in an elderly person, and then you can decide whether you would want to stick a cannula through that aorta when it comes time for bypass surgery. And many surgeons will opt to do the femoral artery, because if you're up there mucking around in the aorta, you're, again, you could dislodge something, your risk of stroke postoperatively could be higher. Carotid health is important, and many of these patients will have blockages in their carotid arteries, and it's important to maintain a good perfusion pressure during the bypass surgeries so that the patient comes out hopefully as intact as they went in. The internal mammary artery, which has been increasingly used, should also be considered in the elderly patient if the surgeon thinks it's technical. And I'll show you a graph just as far as survival with an internal mammary artery versus a vein graft. Bypass duration is an important topic. The longer you're on pump, the more problems you'll have postoperatively with bleeding and cognition. And sometimes complete revascularization may not be possible in an elderly patient, because you really want to keep that pump time down. It would be nice if everybody could be under an hour or as close to an hour as possible. But I think it's important to realize that your patient may come out with incomplete revascularization. And that may be okay, because it's all risk-benefit. We mentioned the fragile tissues. There is a lot coming as to different surgical techniques, even not going on bypass and doing a bypass on a beating heart. And all of these techniques are something that, we don't have many surgeons that are skilled right now, but maybe down the line, this is going to be an option. And if you just need one particular vessel bypassed or two vessels, which are very reasonable, and if you have a skilled surgeon, you may be able to get that done without being on bypass. And so I think down the road, we're going to see more advances, and hopefully that will help the elderly population. And that's the aorta I promised you. And essentially this has been filleted open, and that is just all plaque and hemorrhage. And you can imagine just blindly poking a cannula through that as to why some of these patients are susceptible to stroke. Many surgeons are using transesophageal echo now intraoperatively so that you can get a good look at where you're placing that cannula. And if you see a lot of plaque, they may opt not to put the cannula in there and go somewhere else. This is survival after CABG using the top line, or the yellow line, using the internal mammary artery. So this is survival out 7 years. And again, this wasn't a randomized trial, but it gives you a feel that versus a saphenous vein graft, the internal mammary artery, when it's used, those patients tend to survive longer. It's usually a graft that will last much longer than a saphenous vein graft, which has about a 10-year. If you look at operative mortality in the elderly, it's definitely higher than in the younger person. The elderly, in an acceptable operative mortality for CABG in a young person, 2 to 3%. You wouldn't want to go to any other hospital that said they couldn't give you that. But in the elderly patient, we know that that jumps up significantly, depending on which registry you look at. And I think the one to look at is really the U.S. Medicare records, because they look at everybody. It's not just the surgeons that call in their good operative mortalities. So you want to look at sort of a cross-section. And that can be as high as 11.5%. If you look at other ones, the Society of Thoracic Surgeons database, and of course these are the surgeons that call in, they give approximately a 5% mortality. So the benefit of that bypass surgery really has to be there before subjecting your patient to a high mortality that is not insignificant. The good news is that if you look at 5-year survival, long-term survival post-CABG, it's similar or better than age-matched controls. So to those elderly patients that don't have coronary disease. So if you can get the patient through the surgery, and there's a lot of, I think, hope that their survival is going to be the same or even better. And I think I'm going to skip this slide just for time. It's just more the same. Just quickly, factors affecting survival, particularly early survival. Women and those with small body surface areas in particular, and small coronary arteries, are technically more challenging. And so that has been a problem with immediate survival. And also the emergent status. You preferably don't want to do anybody on an emergent basis, but particularly in the elderly, the mortality will increase. Late survival is affected by the use of the saphenous vein grafts only, without the lima, and also all the risk factors we discussed, the smoking, diabetes. Interestingly, diuretic use, and this is probably because of an increased arrhythmias, and also recurrent infarctions. And interestingly, obesity comes back to haunt us with late survival.
You said the survival rate on women who have small body surface areas is...
And they tend to also have small coronary vessels.
So that's what makes it more difficult.
Yes.
Then. Okay.
Yes.
I would think that they would be, because of their size, overall a better survival rate.
Right. But it's usually in correlation. They also have small arteries as well. Okay, postoperative morbidity, we mentioned stroke, and the incidence in the elderly is between 2 to 10%, and it is a significant cause of in-hospital death. Arrhythmia is a very common, particularly atrial fibrillation, and this is more of a nuisance usually, and hopefully something that can be controlled with medication and often will resolve over time. Bleeding complications are more common, and as we saw in our patient, the rehab period, you have to suspect, is at least twice as long, if not more, compared to a younger patient. So careful selection of candidates is important, and then monitoring for these postoperative complications as well is also very important. So in conclusion, I think that in our elderly patients, we cannot forget risk factor reduction, because we always would like to try to prevent disease or recurrent disease from occurring. So I think we need to focus a lot of our forces there and improve our knowledge base as well as to whether or not cholesterol reduction in someone who's 80 without significant risk factors is going to be helpful. And identification of heart disease is a big stumbling block in the elderly patient. I think your level of suspicion has to be high, whether you're in the emergency room or you're in your office and you have a patient that comes in with vague complaints. Appropriate medical therapy cannot be underscored. We have some very good drugs available for these patients, but the reluctance on the part of physicians who are worried about the side effects of the drug sometimes may actually be more harmful than good. Careful selection of patients for revascularization, because we've seen that there are significant morbidity and mortality associated with both bypass and angioplasty. Don't forget cardiac rehab. We didn't have a chance to really discuss this, but just as in your young patient who has to go back to work, well, your elderly patient has to go back to their life, and they have to do their activities of daily living. And so physical rehabilitation, whether it's after CABG or after a heart attack, is very important in these patients. Better understanding of the drugs we give our patients and how they're metabolized, how they're cleared from the body, is also very important. And I think the big thing is just we need to continue to include the elderly in trials so that we have data which to base our clinical decisions on. And I think I'll end there, and I'll take any questions from the sites and also from here. Okay.
You said earlier that digoxin is one of the drugs that's less adequately utilized by the body as the aging process occurs.
That's
Are you
correct.
seeing physicians that are just stopping the digoxin?
Well, digoxin, the primary, I guess, disease you would use a digoxin would be the congestive heart failure or for control of rate in atrial fibrillation. And to be honest, the experience I've had with digoxin as far as using it for rate control for atrial fibrillation has not been very good. I tend to like beta blockers better for that. There's not enough evidence as of yet, although it seems in heart failure, the digoxin in certain patients is very useful and can improve the incidence of worsening of the congestive heart failure. There's not enough evidence in the elderly to suggest that we should not be using it. But it does seem to give a less of an inotropic effect, less of a squeeze. And that, why that is pharmacologically, we really don't know yet. Are they able to call in, or?
Hello?
Okay, are there any sites with questions at all?
Hello, can you
Do know
hear
who we
us?
had on
This is
today,
Lubbock.
Really?
Somebody's trying to ask a question.
Really? How come?
Brenda said turn that off.
I don't know if they've just gone to the site or. Can't hear you yet.
They see us, but, yeah.
Can you hear us now?
Are we able to do anything to help them? We're in this age of new technology. That's
Over my head.
Okay, can you hear us now? No.
I don't know. Is it mine? Do we know what the problem is? Do we still have our gentleman cameraman back here? Okay.
Here's the mic.
Maybe I can get
I
them to
know.
shake their head. Are you trying? What's that?
Yeah, we're
Oh, you
trying.
hear them there. Oh,
It's Lubbock.
it's from Lubbock.
It's Lubbock.
okay. We maybe should have done a test, but
Oh, I can hear you.
is it anything to do with these?
Well, they
here?
could earlier.
Volume?
Yeah, when we
These were all
started.
the way.
Can you hear us now?
Well, do you want me to come over there and hear them, and then I can come back and give my answer?
Yes.
Can you hear us?
Yes.
Wonderful. We pushed the right button, I guess. I have.
Oh no, we just lost. We just lost them. No.
I have no idea what he's doing.
Are you on now?
Can you hear us?
Yes.
Wait, I'm just going to continue then. My question is, my experience with staphylococcus vein grafts versus internal mammary has been a higher infection rate in the IMA. And I'm wondering if you're seeing that, and given the decreased immune response in the elder, is there any data regarding that?
Am I on, Lily? Okay. That's a very good question, and I know our surgeons sometimes, I don't know that there's any specific trial data on that, but at least our surgeons and diabetics sometimes are reluctant and will use that as the reason for why they have not used the mammary. But again, I think this is variable. I think that for the most part, if the mammary looks healthy, particularly if it looks sizable on the cardiac catheterization prior to the bypass, an attempt will be made to take it down. And I think overall that they feel that the benefit probably outweighs the potential risk for infection. And I know we try our best to have it used here, but sometimes it's just not possible. You're welcome. Can I ask any of the other sites if they have any feedback or questions? Yep. Okay. Well, thanks. And I will make my slides available. I was putting them together last night, and I was going to run the handoff off, and it just never happened. But if I get it to Lily, will that be
That'd be
okay?
great.
Okay.
And she'll get it to us.
Okay.
That'd be great.
Okay.
Thank you so much.
Oh, you're welcome.
Thank you.
I'm
It was
sorry
very
we ran
interesting.
over time.
What goes up must come down. Spinning wheel, got to go round. Talking about your troubles, it's a crying sin. Catch a painted pony, let the spinning wheel spin. You got no money and you got no